Hello, as many of you know who I am, I'm Jeremy Eckhart. I work with the Las Cruces Fire Department. I've been a paramedic here for a couple years. And today I'd just like to share, we're gonna overview of something that helps me when I manage an airway or perform an intubation, and that's a simple acronym that I remembered. It's SODA, S-O-D-A. We're gonna go over what those stand for and how to implement them. One thing that I've used to my benefit in the field is having a systematic approach every single time, so that way when we do go to a very stressful environment and you're having to perform this type of invasive procedure like intubation, it's better to have a systematic approach when you come to those situations. So that way, you know, you're doing everything on your side, your part, to be able to do that in a stressful environment and be successful at it. So what is SODA? SODA is, again, that acronym that I've used to be able to help me have a systematic approach to intubation. The first being suction. Having all those devices ready, and we're gonna be going over those. Number two is oxygen. Oxygen will be anything that, supplying that ventilatory effort towards the patient. You're gonna be your tank, the regulator, your non-rebreather if you're gonna use it, or a BVM if you're gonna have someone assist you with ventilations. It's also gonna be, a lot of people forget this, preparing end tidal, having that ready to go on the BVM when you perform that intubation. So D stands for drugs. We don't perform RSI, however, there is protocols that we have for post-intubation sedation that you potentially might need to do that in situations. I know I have used it in my career before, but it could happen in a ROSC scenario and it can happen in other scenarios. Example would be a head injury and you're managing someone's airway. So make sure that you have the narcotics at the ready, so that way in case you need that, it's ready to go. It's not in the truck, it's not across the room. The last one is A, and that's Airways. So that one right there is not only your basic airway adjuncts, but all the way up to your intubation, and also in case you have a failed intubation, your secondary. So in our case, it would be an LMA. So we'll go through all that of the setup and how we can do that in a systematic way to try to help our success in the field. So the first thing when we approach a patient when we're gonna manage the airway is, we approach from the head. We're gonna use the techniques that we're gonna show you in other videos on how to manage that airway, but I just wanna go over that first letter of that acronym, which is S for suction. So the first thing is, of course, your suction unit. We're gonna be putting a video to show you the insides and out of this, to make sure you should be very proficient in this and understand when it fails, how to fix it, how to make sure that you can actually use this in a very stressful environment. The more practice with this, the better you'll be at being able to suction and maintain someone's airway. Then you have your extension tubing and your yonkers. This is the same thing as the suction unit. We need to know this inside and out. We need to know where the hole is to cover it so we can actually perform suction. We need to know which side goes onto what and how to hook this up. That's not only for paramedics, basics and intermediates. This should be something that everyone knows. Another thing that I like to pull out, rather than waiting for the moment to happen, is just a suction catheter for our ET tubes. Grab one of these out that's appropriate for the size of the endotracheal tubes that can actually go down into it, but have this ready to go, because once we do perform that intubation, if we do need to suction out that airway, we have it ready. We don't have to look into a bag, and we can perform that. Having these things ready to go, that's the number one thing when you look at failed intubations with our video laryngoscopes, is not suctioning the airway. So it's something that I do. It's something that I have ready to go when I first look into the airway, whether there's vomit or not. I have that suction on. I have the yonker in my hand, ready to go to suction even saliva out of the airway. All right, moving on to the second letter of the acronym of SODA, it'd be O, again for oxygen. Just think anything that we need to provide ventilations to the patient. So initially, the type of ventilation, the type of oxygen that we apply to the patient is different. So I'm here in District 6 where I have a squad usually behind me, so I don't necessarily need to utilize a non-rebreather. However, get a non-rebreather out if you need. You can put that on the patient if you're shorthanded and provide them oxygen. Have that ready to go. When the code progresses, we want to pull out our BVM, of course. Have this ready. Even before we even try to attempt, again, there's no point to have this in the bag if we don't have this ready. Make sure the BVM's, the actual valve mask is on. Make sure it works. Have your oxygen ready, whether it's on your non-rebreather or your BVM. And then sometimes people forget this, is we always call for this after we've placed a tube. And we hook that BVM, we listen for those breath sounds, and then all of a sudden it becomes an afterthought of, oh, we need to hook them up to end tidal. Well, rather than doing that later in the call, have this ready to go. Have someone pull it out. Not only have them pull it out, but have them hook it to the monitor. Everyone should know that right here on the side, there's a little swivel door on the monitor. Have this hooked up and ready to go. So that way, the minute that you're able to place that tube, this thing is on the BVM and picking up end tidal immediately. All right, now for the third letter in the acronym of SODA, that would be drugs. I have in the past at a call used a drug to do post-sedation after I intubated someone. So one thing that can help in that situation is having your narcotics ready to go with you, or having someone that has them on them so that way you can get them. But it goes a little bit beyond that. We don't do this very much, but having the equipment ready to go can facilitate that quick transition if you need to, in the case of getting ROSC or in the case of just needing post-sedation if someone has a head injury and you're trying to keep them from pulling a tube after you intubated them because they're trying to get the tube out or breathe past it. Two pieces of equipment. It's pretty easy. Once you have the narcs, you're going to need needles and you're going to need syringes. So make sure you have those with you. In our case, the drug of choice and the drug that Dr. Diven says is Versed. So make sure you have that. Make sure you have the syringe that is appropriate for the amount you need to pull up. Don't grab a 20 cc syringe. So grab usually a 3 or 5 might get you through that. So make sure you have the right syringe and make sure you have the right needle. So that way, if someone does start to need sedation, you're able to provide it quickly. All right, now the last letter of the acronym SODA, Airways. Really the meat and potato of what we're talking about today is having your airways ready to go. It might be initially as far as placing that OPA, just so that way we can provide BVM ventilations or for that non-rebreather, but getting everything ready to go before you even perform that. That includes getting backups. I have my preference on which blade I would choose as a backup, but take your backup out, place it onto the handle, make sure the light works, and set it next to you somewhere so you can grab it in case something goes wrong with the video laryngoscope. The next one is getting the video laryngoscope ready. Having it ready, having it turned on, understanding how to use it. Lubing the endotracheal tube that you're going to use and placing it into the video laryngoscope. I know recently I pulled one of these out and there was a stylet already in it. So making sure that if you did have a stylet, you'd want to pull that out for the video laryngoscope. So having that ready to go, apply the lube so that way it moves freely for your success. Having that ready, a lot of times people forget one thing: get that 10 cc syringe out so that way you can inflate your ET tube. I've done it before. I've intubated someone and not had this out, and then it becomes a problem. So make sure you have that 10 milliliter syringe out and you test the bulb to make sure that endotracheal tube is going to work. Another thing I like to have with me is a bougie, just in case something does happen to that cuff or the tube isn't working right, I can place this into the trachea and switch out a tube. So having this and not having to look for it when I need it will help. Having multiple size ET tubes ready to go, one above and one below that you think you're going to need for intubation, having that ready to go next to you will help, not only if your first cuff fails, but if you're not able to pass that tube and you need a smaller one, or perhaps you need a larger one, it's ready to go next to you and you don't have to run through a bag. Another thing you should prepare and have next to you that goes with our Airways is a tube tamer. We intubate a lot, and whether it's tape or a tube tamer, just have that means to secure that tube readily accessible, so that way you're not looking through bags trying to hold a tube into someone's airway and you're rummaging through a bag. So have someone grab this out, have it next to you, so that way you know exactly where it is. And lastly, if everything you did is right, you run through soda, you've done everything you can, sometimes it's just a difficult airway, or there's things that we can't overcome that will make it impossible or very, very difficult to place an airway. So have your secondary airways ready to go. Your advanced airways, in our case of an LMA. If you do have a failed airway, then have this ready. Have the cricotomy kit ready to go, so that way you're not looking for it. I've been on a call where I asked someone for one of these and they did not know where it was in the bags. So had I needed it, I wouldn't have had it. So make sure that this, if you think anything is going to happen, facial trauma, if you think you're going to be unsuccessful with intubation and you have a failed airway, make sure you have this in arm's reach, so that way you're not looking for it, because it's going to be a stressful procedure that you're going to have to do, and looking for it is just going to compound the situation.